Our first step will be to deplaque her teeth and the root surface utilizing a periodontal curette. Following up here, I'm using a periodontal hoe to clean the root surface and make them biologically acceptable, or in other words, clean enough to receive the connective tissue graft and have the connective tissue fibers embed into the root surface itself. Utilizing a 15C scalpel, which is a very small scalpel blade, I will trace along the existing gum line to open up and create a pocket which will allow me to place the donor into. In doing a gum graft or any type of a tissue transplant, one of the key factors is surface area. In other words, we need the donor tissue that we will transfer from the palate down into this area to have adequate blood supply to remain viable and to reestablish its nutrient source, which is the blood. So we're creating a pouch here which will allow for blood supply to come from the collateral bone as well as the bone that's on these two adjacent teeth that we're grafting, and by the overlying existing gum tissue. Now this patient has a very tight lower lip. In the dental terms, we would call she has a pathologic frenum. In other words, she has a piece of some muscle, if you will, that goes from her lip to her gum tissue that over the years has been a contributing factor in her gum recession on these two teeth. So what I'm trying to accomplish with my scalpel is to eliminate any musculature that will want to tug on her existing gum tissue as well as her new gum tissue and potentially cause us recession in the future. Now I'm creating a pouch again that has enough surface area, and you see me extending the pouch about a half tooth on either side of the two teeth we're grafting so that we have adequate blood supply to keep the graft viable. Now I'm coming back with the periodontal hoe, scraping the roots clean. Again, we're just trying to make it biologically clean enough to accept the donor tissue and have the donor tissue embed into the root surface. My measurement that I need here is roughly 12 millimeters in length. So utilizing a 15 blade, which is different from what I used before in the front, which was a 15C. The 15 is a little bit larger. I'm making two paralleling incisions. So creating a railroad track, if you will. The most lateral of those two, or the one closest to the teeth, goes to the patient's bone. That's roughly about 3 millimeters in thickness on this patient. So that incision is going to bone. The second incision is relatively superficial. It is about 1 millimeter below the surface, which allows us to take out a wedge of tissue roughly 2 millimeters thick that will be transferred onto the two lower central incisors as our graft. Now ideally, when we're trying to cover exposed roots, the height of your donor must be greater than the amount of gum recession that the patient has. So what you see me accomplishing here is I'm harvesting and taking the graft from the palate. Now I'm just injecting a little 1 to 50 epinephrine. This is what we use in dentistry to control bleeding. My graft there is roughly 10 millimeters tall. So we're going to take our graft and we're going to place it into the pouch that we created on the 2 teeth that we're grafting. Now I'm positioning the donor tissue, the donor connective tissue, in place utilizing 5/0 chromic gut suture. This material is very small. It dissolves in roughly 5 to 7 days on most patients. And utilizing a suturing technique that we call a sling suture, which wraps around the back side of the tooth, allows us to position the donor exactly where the crown and the root of the tooth meet. We want the new gums to be positioned so that the roots that were previously exposed are now completely covered. The sling suture allows us to position the tissue in its proper vertical position relative to each individual tooth. So I'll do a second sling suture here on her right central incisor. You see me wrapping around the back side. So the tooth somewhat acts as a pulley by utilizing the sling suturing technique. And we'll tie our knot. And you can see immediately that the gum recession is eliminated, and you probably can appreciate from this angle here the thickness of the donor tissue. It's definitely, and it's probably obvious to all of our viewers, that the donor tissue is at least twice as thick, maybe 3 times as thick as her existing gum tissue. So I would expect this to hold up very well for the duration of this patient's lifetime, given that she practices good home care and seeks professional cleanings as well. But instantly we've increased the thickness of her gingival tissue, which creates a barrier that again is 2 to 3 times thickness. So the oral bacteria has a much harder time reaching the patient's jawbone and dissolving it than ever before. And that's the beauty of the connective tissue graft. We can actually create a biological barrier that prevents the oral bacteria from gaining access to the patient's jawbone, and hence we stop bone loss. That's really the key to the connective tissue grafting technique. In my opinion, it's definitely the gold standard by which other gum grafting procedures are compared to, and because we're utilizing the patient's own tissue as opposed to any other type of donor tissue, cadaver tissue, etc., there's no chance of rejection. The key to this procedure is working quickly as you take or harvest the tissue from the palate and transfer it down into place. So what we expect to see here is a complete elimination of the gum recession, 2 to 3 times thicker gum.